Hello everyone, I Dr. Abhinav Gupta is back with my new video on lymphedema. Today we will discuss about the introduction, causes, diagnosis, assessment and treatment of the lymphedema. Basically the physios who have already worked in the oncology division of the hospital must have heard and commonly assessed the conditions of patients with lymphedema. So coming directly to the introduction, what is lymphedema? Lymphedema is an abnormal accumulation of protein-rich fluid in the extremities which is occurring because of the low mechanical insufficiency of the lymphatic system. Basically, it is related to in the treatment of breast cancer, and it is occurring because of the disruption of the axillary nodes or axillary bed by the removal of or excision of lymph nodes or the radiation therapy to the area. So patients who are undergoing these kind of procedures are at lifetime risk of developing lymphedema. Even not only to the upper extremity, it can also occur in the ipsilateral upper quadrant or in the remaining breast tissues. If we talk about the epidemiology or the incidence of lymphedema, the onset of lymphedema may occur at the time of treatment or may be delayed several decades after the treatment of breast condition. The frequency of upper extremity lymphedema after ALND or RT, what ALND stands for, that is axillary lymph node dissection, or RT stands for radiotherapy. The range is from 6% to 33.5%. There is that much big variability between the range. Basically, to study lymphedema, we are following two kind of classification systems. First is the American Physiotherapy Association, that is APTA system, that uses the maximum girth between the involved and the uninvolved limb to identify the degree of lymphedema. In this kind of system, the maximum girth difference should be less than 3 cm is considered as mild lymphedema. If the difference is between 3 to 5 cm, then the lymphedema is considered as moderate, and if the difference is more than 5 cm, then it is severe. Then another classification system comes, that is the International Society of Lymphology, that has derived criteria, that is stage-wise criteria. Stage 1 is known as reversible lymphedema. If we come to stage 2, that is spontaneous irreversible lymphedema, and stage 3 is lymphostatic elephantiasis. Now if we talk about the prevention, as we always discuss in our videos, that prevention is always better than cure. So the management of lymphedema should always begin with preoperative evaluation and education to the patient. This should include recording baseline girth, volume measurements of the bilateral upper extremities, and the most important is patient education. So educating the patient about the arm and hand care guidelines and noting any factor that may put the patient to an additional risk of developing lymphedema is very important. So having baseline measurements of girth and volume facilitates earlier detection and treatment for lymphedema. But if we talk about today's scenario, there is currently no gold standard for the definition of lymphedema. So a prospective cohort study tested the predictive and discriminatory validity of using the patient symptom related to lymph volume changes to determine the presence of clinically measurable lymphedema. Means they have used a predictive criteria. As I have told you earlier, that there is no gold standard study till now to assess or measure or to frame a standard guidelines for lymphedema assessment or management. So what it was a prospective study which was important for using, it was the importance of using self-reported symptoms were in the study, and it was suggested that the two symptoms were very predictive and important for a person to understand whether he or whether she is having lymphedema or not. that is the heaviness in the arms for more than 3 months, swelling, and the difference of more than 2 centimeters. Now, directly coming up to the arm care guidelines. What are the basic guidelines to take care of an arm for the patient who is having lymphedema? The patient should be instructed about the arm care guidelines to decrease the risk of developing lymphedema. Basically, risk reduction practices include skin care, modification of activities and lifestyle, avoiding limb constriction, using compression garments, and avoid extreme temperatures. That's why we tend to avoid use of hot packs in case of lymphedema. Then coming up to the risk factor, what are the basic risk factors for the patient who are having lymphedema? In addition to educating the patient about risk factors or risk reduction practices, it is also important to note any factors that may put the patient to an additional risk for the development of this lymphedema. Patient risk factor includes the stage of cancer or the stage of diagnosis at which the cancer was diagnosed, age of the patient, whether she is obese, hypertensive, or whether the patient received chemotherapy or not. Patients with more advanced nodal disease are likely to have more extensive axillary surgeries along with axillary radiotherapy, which increases the risk of developing lymphedema. Older age patients, if we talk about older age patients, geriatric population, these patients have also been found to be associated with an increased risk of lymphedema, which is subsequent to radiotherapy. Obesity is also one of the strong predator of arm edema, and hypertension is also increasing the risk to develop the same. Now, if we talk about the treatment, what is the best possible treatment for lymphedema? So, if lymphedema is diagnosed with the patient through the criteria that we have discussed earlier, or whether the lymphedema we have discussed as per the APTA guidelines or as per the International Society guidelines, if lymphedema is diagnosed, early intervention is very necessary. Although there is no cure for the pathology or pathophysiology of the breast cancer treatment related lymphedema, but treatment can decrease and maintain the size of the girth size of the limb. So, treatment for lymphedema is basically focused on the physiotherapy, assessment, and management. So, we physios are playing a major role in the oncology division of the hospital, especially in the post-mastectomy cases. So, what we can do is we can incorporate complete decongestive therapy for the patient, which is a two-phase program that consists of a treatment phase and a maintenance phase. The use of CDT, basically I'll use the term CDT to again and again not to keep repeating the complete decongestive therapy. Though CDT is becoming much more wider and accepted and is now considered as the standard care by the International Society of Lymphology. The treatment phase involves basically the 4 components. First is the skin and the nail care. Second is the manual lymphatic drainage, that is MLD. Another 2 parts are, third part is compression bandaging, and fourth one is therapeutic exercises. Now MLD, manual lymphatic drainage, is a manipulative technique that is used to facilitate lymphatic flow, lymph flow, by increasing the pumping rate of the superficial lymph vessels. And the treatment is performed daily with reassessment of the girth and also reassessment every week, so that we can see the observable differences between the 2 readings. If patient's limb girth and volume measurements indicate a reduction when compared to those of the previous week, then the patient should continue for further management with the manual lymphatic drainage therapy. But if the patient lymph measurements is at plateau as compared to the previous weeks and the readings are not getting changed, then the patient begins with the maintenance phase. The maintenance phase basically consists of another 4 to 5 components what we can say. First is we will continue to care for skin and the nail beds. Then self manual lymphatic drainage will be taught to the patient. Home exercises will be taught to the patient. Compression garments are very important to get used, and self compression is very important. Patient will be taught to self compress the lymphedemous limb. Now, if we again talk about the treatment phase, during the treatment phase, it is very important that the patient adhere to all the 4 components of the program and maintain the compression bandage on the limbs, as it is very important that this is a combination of 4 components through which in a CDT, complete decongestive therapy, basically what we are doing is we have to maintain the combination, as we are taking care of nail beds, we are taking care of the skin of the patient. Then on the second aspect, we are doing manual lymphatic drainage techniques that are decreasing the lymphedema. Then to maintain that decreased girth, we have to maintain that compression bandaging. And finally, to keep the patient's lymphatic drainage faster, we have to tell them the few exercises so that they can carry on with the same protocol. Now, if we talk about the resistive exercises, role of resistive exercises in lymphedema, the role of resistive exercises is still very controversial and patients are not getting that much relief. If we compare as per the study results, patients are not, there is no that much significant difference between the patients who have received resistive exercises and those who have not received the same. So once, if we talk about then what we were talking, that all the phases of CDT in a treatment phase, if once the treatment phase is completed, the patient begins to start with the maintenance phase, as the maintenance phase is the lifelong self-care of the patient. It is therefore important for the patient to understand the lymphedema and the importance of maintenance phase over the time. But if we only talk about lymphedema, if we are not talking about all the associated symptoms, all the components, then there is currently no cure for lymphedema. Therefore, once a diagnosis of lymphedema is made, it must be monitored over the course of patient's life, as it goes lifelong with the patient. It can also develop after decades. The patient should undergo reassessment for the limb girth and volume for every 6 months to monitor the condition, as well as the redirect therapy as appropriate. So, if we talk about further researches or studies about the lymphedema, a qualitative study was performed to describe the experience of managing lymphedema in cases of breast cancer. So the study demonstrated or determined that the participants came to the realization that their arm could get bigger if they did not continue taking care of their lymphedema. They also realized that not taking care of their lymphedema would intensify their physical sensations such as discomfort, pain, soreness, burning sensations, ache in the limb region, as well as they also felt kind of rigidity, tiredness in the limb because of heaviness, and the upper quadrant was also involved. So as I have told you in this video, that it is a lifelong process and patient need to reassess and take care of the limb throughout the life, even after the treatment of the breast cancer. Now, if we conclude the video as a whole, what we were trying to make you learn, that in conclusion, the recommended guidelines for lymphedema management should include preoperative assessment, patient education for lymphedema prevention, early detection, basically through symptoms, and limb measurement assessments every week, and early intervention with a comprehensive treatment program once a lymphedema is diagnosed. These are the few things which we can incorporate, and continue assessment and maintenance and patient education every 6 months is very, very important in cases of lymphedema. Thank you everyone for today. If anyone have any query, you can contact us at healthcaremakino@gmail.com. Thank you.